Morning, everyone. So we are here with a very important topic to discuss adjuvant analgesics, and this topic will be discussed by GCRI team. And I will request Dr. Bhavana to introduce the speaker and the moderator. Dr. Bhavana, please introduce. Dr. Bhavana is faculty of GCRI and she must be knowing more than what I will say about the speaker and moderator. So I will request Dr. Bhavana to introduce Varun and Ravi. Dr. Bhavana.
Good morning, ma'am. Good morning.
Yes, good morning. Good morning. Go ahead.
Yes, ma'am. Yes. Good morning, everyone. Dr. Varun is very sincere and enthusiastic to learn more and more, ready to volunteer any clinical or extraclinical activities. Ditto for Dr. Ravi. He is also hardworking and knowledgeable. He has done MD in anesthesia from GCRI, FIPM fellowship in pain management under Dr. GP Dureja from Delhi, and also done fellowship in palliative medicine at GCRI and then working as assistant professor at GCRI. Dr. Varun, his presentation.
Thank you. So anyone has any question, please write down in the chat box, and I expect that MDs at least they should ask questions and queries if they have. And then we will take an answer from speaker and the seniors, those who are joining the classes. Okay, go ahead, Varun.
Good morning, everyone.
Good morning, Varun. Share your slides.
Okay, everyone visible? Slide.
Yeah, we can see. Go ahead.
Okay. Good morning. I am presenting today Adjuvant Analgesics Part 2. Today we cover the contents like adjuvant analgesic used in the bone pain, dexamethasone, calcitonin, bisphosphonate, adjuvant analgesic in gastrointestinal pain, in genitourinary pain, and for the myofascial pain and the muscle spasm. First of all, we discuss calcitonin. It is a 32 amino acid linear polypeptide hormone that is produced in human primarily by the parafollicular cells, also known as a C cell of the thyroid. The calcitonin receptor is found on the osteoclast in the renal tissue, in the ovary, in the testes, and in the central nervous system, and is a G protein coupled receptor. The hormone participates in the calcium and phosphorus metabolism. Calcitonin counter the parathyroid hormone activity and lower the blood calcium level by inhibiting the intestinal calcium absorption and intestinal osteoclast activity. This is the figure showing the mechanism of the calcitonin, which is secreted by the thyroid gland and which lowers the calcium level in the blood, inhibit the calcium absorption from the intestine, promote the deposition of the calcium into the bone, and inhibit the osteoclast and stimulate the osteoblast. Inhibit the calcium reabsorption in the kidney and excretion in the urine. Pharmacology of the calcitonin absorption intranasal. It is rapidly but highly variable and lower than intramuscular administration, metabolized by the kidney, blood, and peripheral tissue. Bioavailability is 66% for intramuscular and 71% for subcu. Half-life elimination is 58 minutes for the intramuscular and 59 to 64 minutes for the subcu. Time to peak plasma concentration is 23 minutes and 10 to 13 minutes for subcu and nasal route. Excretion is by urine and clearance is for salmon calcitonin. It is 3.1 ml per kg per minute. Indication for the calcitonin are the mainly used for the hypercalcemia injectable and phantom limb pain or the pain from spinal stenosis, complex regional pain syndrome, postmenopausal osteoporosis, Paget's disease of the bone, osteogenesis imperfecta tarda, prevention of the osteoporosis, acute pain which is associated with osteoporosis and the osteoarthritis. Contraindication is hypersensitivity to calcitonin or any component of the formulation is contraindicated, and undesirable effects are facial flushing, flushing of the hand and feet, erythematous rash, abdominal pain, nausea, lymphadenopathy, malignant neoplasm, or the locally inflammation at the injection site, or the dizziness and paresthesia. Dosage for the hypercalcemia, calcitonin can be given 4 international unit per kg, sub-Q or IM every 12 hours, and it may increase up to the 8 unit per kg. For the Paget's disease, initial dose is 100 units sub-Q or IM per day, and for the maintenance, it can be used as a 50 unit per day or the 50 to 100 unit every 1 to 3 days. And for the osteoporosis, the indicated for the treatment of the postmenopausal osteoporosis in the woman greater than 5 years of the postmenopause, and the 100 unit sub-Q or intramuscular every other day with calcium and vitamin D. And also available as a nasal spray, and one spray container 200 unit per day, and it can be used in the alternate nostrils daily. This is the figure showing the nasal versus intramuscular calcitonin for the bone pain, which suggested that intranasal route is more effective for the pain in the bone meds than intramuscular route. And this is the formulation of the calcitonin for the injectable and the for nasal solution. The one study showing the continuous sub-Q administration of the high-dose salmon calcitonin in the bone meds, which have the result with satisfactory analgesic effect in the bone pain at the dose of 400 units per day sub-Q administration. Next one is a bisphosphonate. They are a stable analog of the pyrophosphate, which is a naturally occurring regulator of the bone metabolism. Bisphosphonate are of two types, nitrogen containing and non-nitrogen containing. Nitrogen containing are alendronate, pamidronate, zoledronate, and hydrondonic acid. And non-nitrogen containing are the sodium chlordronate and disodium etidronate. They have high affinity for the calcium ion and bind rapidly to the hydroxyapatite crystal in the mineralized bone. Bisphosphonate are subsequently released and taken up by the osteoclast and interfere their function or induce their apoptosis. The figure showing the mechanism, it is taken up by the bone and released, then osteoclast taken up the bisphosphonate. So nitrogenous bisphosphonate alter the homo and HMG coenzyme A pathway, and non-nitrogenous bisphosphonate compete with the ATP and causes the apoptosis of the osteoclast. Indication for the bisphosphonate are the tumor-induced hypercalcemia, prevention of the skeletal-related event, and the pain in the patient with advanced malignancy, adjuvant analgesic for moderate to severe pain, treatment of the bone loss in patient receiving the hormone deprivation therapy, prevention of the bone mets in the postmenopausal woman, osteoporosis, Paget's disease of the bone, and long-term corticosteroid therapy. Contraindication to the bisphosphonate are the hypocalcemia, esophageal abnormality, and inability to sit up for the 60 minutes after the oral injection. Drug interaction, concurrent use increase the risk of the hypocalcemia and hypomagnesemia with aminoglycoside, and it may cause the hypocalcemia and dehydration with low diuretic. And renal impairment with the other nephrotoxic drug and thalidomide can occur in the multiple myeloma. Undesirable effect of the bisphosphonate are the transient pyrexia and the flu-like syndrome, which can be more common with the IV nitrogen-containing bisphosphonate than fatigue, headache, anxiety, infusion site reaction, or the deterioration of the renal function, hypokalemia, jaw osteonecrosis, ocular toxicity, angioedema, and renal toxicity. An oral product in the particular may cause the anorexia, dyspepsia, nausea, vomiting, abdominal pain, diarrhea, and constipation. The jaw osteonecrosis, all the bisphosphonate have been implicated as a risk factor for the jaw osteonecrosis. The jawbone may be particularly susceptible to the osteonecrosis because of combination of the repeated low-level local trauma like chewing or the dentures and the easy of the infection from the microbe. So the trauma and infection increase the demand for the bone repair, which the bisphosphonate inhibited and bone cannot meet. So resulting in the localized bone necrosis and anti-angiogenic effect of the bisphosphonate also contribute to the jaw osteonecrosis. Renal toxicity, onset of the decreased renal function varies but often manifest within the 2 months of the starting the treatment. Mild impairment tend to recover a few days to several months after discontinuing the bisphosphonate. Ibandronic acid is authorized for the use in the severe renal failure, and the dose should be reduced in moderate to severe renal impairment, like creatinine clearance less than 50 to 30 ml per minute. Per oral dose can be 50 milligram for alternate day, and if the creatinine clearance is less than 30 ml per minute, then ibandronic acid can be used as a 50 milligram per oral once a week. Dose reduction for the zoledronic acid, it can be used as a 4 milligram IV if the creatinine clearance is greater than 60 ml per minute, and if 50 to 60, it can be used as 3.5 milligram, then 3.3 and 3 milligram for 30 to 39 ml per minute for creatinine clearance, and less than 30 it is contraindicated. The IV dosage and the mechanism pharmacokinetic includes zoledronic acid IV dose 4 milligram with onset of action less than 4 days, maximum effect 4 to 7 days, and duration of effect are for the 4 weeks, and it restores the normal calcium of 90%. Amidronate for IV dose, it can be used as a 30 to 90 milligram less than 3 days, and maximum effect is achieving in 5 to 7 days, and duration of effect is 2.5 weeks, and restore the normal calcium in 70 to 75% cases. And ibandronic acid used as a 2 to 6 milligram IV, onset of action less than 4 days, and maximum effect achieving within 7 days, and duration of effect is 2.4 weeks for the 4 milligram and 4 weeks for the 6 milligram. Ibandronic acid is a third generation bisphosphonate, which can be used as a for oral dose also, and only bisphosphonate which can be used as a severe renal impairment, and normal dose of ibandronic is 50 milligram per oral once daily. Some research articles showing the beneficial role of the bisphosphonate for the metastatic bone pain, this showing the oral clotronate, IV pamidronate or zoledronic acid showing analgesic effect in some studies, and both IV and oral ibandronate reduce the bone pain in the breast cancer patient with bone meds. Then we are discussing the gastrointestinal adjuvant analgesic. First one is dicyclomine. Dicyclomine, also known as a dicyclovarin, is competitively inhibit the neurotransmitter acetylcholine at the receptor site within the cholinergic system. This inhibit lead to the blockage of the parasympathetic nervous system. Onset of action of the dicyclomine is 1 to 2 hours. Duration is up to 4 hours, and absorption orally rapidly and well absorbed. Bioavailability for the IM injection is 2 times more bioavailability than oral administration, and for peak concentration it takes 60 to 90 minutes, and excreted via the urine 80% and feces 8%. Indication for the dicyclomine is like irritable bowel syndrome, specifically hypermotility or means diarrhea type. And as 2016 clinical guideline recommend the dicyclovarin and other antispasmodic for the irritable bowel syndrome with diarrhea as a first line treatment. Is contraindicated in the obstructive disease of the GI tract or severe ulcerative colitis, reflux esophagitis, unstable cardiovascular status in acute hemorrhage, obstructive uropathy, glaucoma, myasthenia gravis, and breastfeeding woman or infant less than 6 months of the age. Adverse effect of the dicyclomine can range of anticholinergic side effects such as dry mouth, nausea, blurred vision, dizziness, confusion, severe constipation, stomach pain, heart palpitation, difficulty in urine and seizures. Normal dosage for the dicyclomine is 20 milligram oral or IM, and in children it can be used as a 5 to 10 milligram. Another one is a hyoscine, which is also known as the scopolamine or the devil's prick. It is a natural or synthetically produced propane alkaloid and anticholinergic drug. It blocks the action of the acetylcholine at the parasympathetic site in the smooth muscle, secretory gland, and the CNS. It increases the cardiac output, dies the secretion, antagonizes the histamine and the serotonin at the usual recommended dose, and it causes the blockage of the muscarinic receptor at the cardiac node and is parasympatholytic. So block the vagal activity and increase the heart rate. Hyoscine, butyl bromide and hydrobromide. For butyl bromide, bioavailability for oral is less than 1% and onset of action less than 10 minutes for the sub-Q, IM or IV route. And for peak effect, it takes 15 minutes to 2 hours and plasma half-life 1 to 5 hours and duration of action is less than 2 hours. For hydrobromide, it is 60 to 80% sublingual, 3 to 5 minutes for IM and 10 to 15 minutes sublingual for onset of the action. And peak effect can be obtained within 20 to 60 minutes sublingual or for transdermal patches 24 hours. Plasma half-life is 1 to 4 hours for the hydrobromide. Indication of the hydrobromide is for the prevention of the motion sickness or the drying secretion, siluria, death rattle, and inoperable bowel obstruction. And for the butyl bromide, which is also known as Buscopan, indicated for the smooth muscle spasm, drying secretion, including siluria, drooling, death rattle, noisy respiratory secretion, inoperable bowel obstruction, paraneoplastic pyrexia, and the sweating. Contraindication for the narrow angle glaucoma, prostatic hyperplasia, pyloric obstruction, and the paralytic ileus. It is competitively block the prokinetic effect of the metoclopramide and domperidone. And the undesirable effect are anti-muscarinic effect of the mydriasis, tachycardia, dry mouth, urine retention, flushing, heartburn, and the constipation. Doses for the hyoscine hydrobromide are for the drooling or the siluria, it can be used as a transdermal patches of 1 milligram for the 3 days, and if necessary, we can use the 2 patches concurrently. And for the death rattle or the noisy respiratory secretion, sub-Q 400 microgram state and continue with 1.2 milligram per 24-hour continuous sub-Q infusion. And if necessary, it can be increased up to the 2 milligram per 24-hour infusion and 0.4 milligram for the rescue doses. And hydrobromide used as an inoperable intestinal obstruction start with 20 milligram sub-Q state and 60 milligram per 24-hour infusion. And maximum reported dose is 300 milligram per 24 hours. For death rattle, it can be used as also 20 milligram sub-Q state and 60 milligram for infusion. And for higher dose, it can be used as a 120 milligram for 24-hour infusion. Some articles showing the scopolamine page for the cancer-related nausea, vomiting, and the use of the scopolamine in the palliative care for the various indications. It can be used as a transdermal page of the scopolamine. Then other one is a Octaviotide. It is a synthetic hormone and analog of the somatostatin with a longer duration of the action. There are the 5 somatostatin receptor SST1 to SST5, and each mediating a different biological action of the somatostatin. And the figure showing the mechanism of the somatostatin on the different receptor for the brain and pituitary. It acts on the SSTR1 to 5 and inhibit the norepinephrine, corticotropin releasing hormone, thyroid releasing hormone, TSH and GH. In the eye, it acts on the SSTR1 to 3 receptor and inhibit the VEGF. For the gastrointestinal tract, it reduces the secretion of the gastrin, secretin, gastric acid, motilin, cholecystokinin, VIP, pepsin, GIP, and intrinsic factor, and bile. For pancreas, it reduces the secretion of the glucagon, insulin, and PP. And for adrenals, it acts on the SSTR3 and 5 receptor and inhibits the secretion of the medullary catecholamine and aldosterone. Neuroendocrine tumor express the various receptor profile, but generally the SST2 and the SST5 are the predominant receptor for the neuroendocrine tumor, and the octaviotide and the lanreotide bind with high affinity to the SST2 and the SST5 with moderate affinity to the SST3 receptor, and the new somatostatin analog Pazireta with different receptor affinity profile, which is under investigation. Potentially, this could be improve the symptoms which are or have become the refractory to the octaviotide. General onset of action for the octaviotide is 30 minutes and plasma concentration maximum 30 minutes for sub-Q. Plasma half-life is 1.5 hours and duration of the action is 8 hours. There is a anti-tumor effect of the somatostatin analog. It exerts this anti-tumor activity through both the direct and the indirect mechanism. In direct mechanism, it inhibits the growth factor signaling, and growth factor signaling inhibition inhibit the cell cycle, pro-apoptotic effect, and inhibit the growth factor effect. And through indirect anti-tumor effect, it inhibit the angiogenesis, modulate the immune system, and inhibit the release of the growth factor and trophic hormone. So this is the anti-tumor effect of the octaviotide. Cautions with octaviotide are for type 1 diabetes mellitus on the insulin, cirrhosis and renal failure who require the dialysis. It may cause the gallstone, and avoid the abrupt withdrawal of the short-acting octaviotide after the long-term treatment. Drug interaction increase the bioavailability of the bromocriptine and reduce the plasma cyclosporine concentration and inadequate immunosuppression of cyclosporine. Undesirable effects are constipation, diarrhea, nausea, flatulence, glucose intolerance, hair loss, loss of appetite, skin rashes, and the thyroid problems. Dose recommendation for the sub-Q octaviotide for the different indication we can use in different doses. Like for acromegaly, it can be used as a 100 to 200 microgram TDS. For intractable diarrhea, 250 to 500 microgram per 24 hours, which can be maximum used as a 1500 microgram per 24 hours. For intestinal obstruction, it can be used as a 250 to 500 microgram, and for 24-hour infusion, maximum dose 750 microgram. Tumor anti-secretory effect is at the 50 to 100 microgram twice a day dose, and for the ascites or the bronchoria, it can be used as a 250 to 500 microgram per 24 hours. Some articles showing the role of the octaviotide in the palliative care, suggesting the use with favorable result in the management of the gastrointestinal disorders such as hemorrhage or the diarrhea, short bowel syndrome, fistula, or the intestinal occlusion in the palliative care setting, and the favorable result occur with important side effect underlining the potential role of the drug. And sub-Q octaviotide in the treatment of the pain in the advanced cancer patient. Also, gastrointestinal pain relief are there. Then analgesic, which can be used in the genitourinary symptoms. Tamsilosin. Tamsilosin is a selective competitive antagonist at the postsynaptic alpha 1A and 1D adrenergic receptor. The 70% of the alpha 1 adrenoreceptor in the prostate are located in the prostate area. They are alpha 1A subtype. And by blocking this adrenoreceptor, the smooth muscle in the prostate are relaxed and urinary flow is improved. And the blocking of the alpha 1D adrenoreceptor, which relax the detrusor muscle of the bladder, so it prevents the storage symptom. Specificity of the tamsilosin focus the effect of the target area while minimizing effect in the other areas. The pharmacology include the metabolism, which is in the liver primarily by the CYP2D6 and CYP3A4, less than 10% is excreted unchanged in the urine. Bioavailability is 55 to 100%, and onset of action 4 to 8 hours, and maximum benefit can be achieving within 4 to 8 weeks. Plasma half-life is 9 to 15 hours, and duration of action is less than 24 hours. Indication for Tamsilosin is symptom associated with benign prostatic hypertrophy or radiation-induced urethritis. Before trial without catheter inserted for the acute urinary retention in the man, and medical management of the urinary stone. And it is contraindicated for the symptomatic postural hypotension and hypersensitivity to the drug. Drug interaction with epidural morphine or sildenafil or any other alpha-1 antagonist, and it is metabolized mainly by the CYP2D6 and CYP3A4. So caution should be taken with the inducer or the inhibitor of these two enzymes. Undesirable effect of the Tamsilosin are dizziness, orthostatic hypotension, ejaculatory impairment, headache, asthenia, drowsiness, insomnia, bitter taste, nausea, and impotence or the erectile dysfunction. Dose and the use for the hesitancy of the maturation, it can be used as a 400 microgram for oral once daily, and if necessary, we can increase to the 800 microgram once daily after the 2 to 4 weeks. Then other adjuvant analgesic in the genitourinary pain. The mechanism for this adjuvant are they act on the M3 receptor, and the M3 receptor sites in the bladder are the bladder base, bladder neck, and the proximal urethra. So the M3 receptor parasympathetic and the neurotransmitter for this M3 receptor are the acetylcholine. The mechanism of this antimuscarinic drug are the inhibition of the acetylcholine effect, which is generated from the non-nervous sources like urothelium or leaking from the cholinergic nerves during the filling phase. The antimuscarinic may inhibit the detrusal overactivity or the urgency. So the release of the acetylcholine from the nerve and the urothelium, which enhance the myogenic activity, increase the nerve afferent nerve activity, and initiate the maturation. So anticholinergic drug inhibit the effect of the acetylcholine, and their effect is at anticholinergic side. The first one is oxybutynin and flavoxate. Oxybutynin is a selective for the M1 and M3 receptor subtype, metabolized by the CYP3A4, and bioavailability is 2 to 11%, and half-life is 2 to 3 hours per oral, and 30 to 60 minutes for time to peak plasma level. And flavoxate is a drug with direct spasmolytic action on the smooth muscle, especially of the urinary tract. And the direct relaxant effect on the smooth muscle is via the phosphodiesterase inhibition. It is also metabolized unknown to active metabolite, and bioavailability is 95%. Half-life is 3.5 hours, and for peak plasma level, it takes 2 hours. Indication for oxybutynin in overactive bladder, urgency, nocturia, and frequency, and it is contraindicated in the bladder outflow obstruction, GI obstruction, including paralytic ileus, predisposition to the narrow angle glaucoma or the myasthenia gravis. And for the flavoxate, it is indicated in the antispasmodic to provide the symptomatic relief of the dysuria, nocturia, suprapubic pain, urgency or frequency, and incontinence in patients with cystitis, urethritis, erythrocystitis, and contraindicated in pyloric or the duodenal obstruction, and gastrointestinal hemorrhage, obstructive intestinal lesion. Drug interaction of oxybutynin is inhibitor or the inducer of the CYP3A4 enzyme. Undesirable effects are dry mouth, cognitive impairment, delirium, particularly in the frail and particularly in the elderly, nausea and the abdominal discomfort, and the skin reactions. Dosage of the oxybutynin are the 5 mg twice a day to 4 times a day, and maximum recommended dose is 20 mg once daily. And oxybutynin also available as a transdermal patches of 3.9 mg per 24 hours. And brand name are for oxybutynin, they are Oxyspas, Topan, oxytropase. And for flavoxate, it enhances the tachycardiac effect of the cannabinoid. It is a CNS depressant, may enhance the sedative effect. And undesirable effects are palpitation, tachycardia, confusion, drowsiness, headache, nausea, vomiting. Dosage for the flavoxate are the 200 milligram tablet, 1 tablet 3 times a day. Tolterodine, solifenacin, and propenthalin, they are also the anticholinergic drug. Mechanism are mostly tolterodine is M3 selective, while the solifenacin and propenthalin have no any specific receptor selectivity. Mostly they are M3 receptor selective. The metabolism are mainly by the CYP2D6 and CYP3A4 for the tolterodine and solifenacin, and for propenthalin it is metabolized hepatic by the hydrolysis to the inactivate metabolite. Bioavailability is 53%, 90%, and 10 to 25%, and it is excreted via urine or feces for the tolterodine and solifenacin, and propenthalin it is mainly excreted only in the urine. Indication are for tolterodine, it is overactive bladder with symptom of urge, urinary incontinence, urgency and frequency. Solifenacin also for neurogenic detrusor overactivity and symptom of the frequency, urgency. And propenthalin is a peptic ulcer, used in the peptic ulcer adjunctive therapy in the treatment of the peptic ulcer, and also used to treat the detrusor overactivity. Contraindication is hypersensitivity to the tolterodine or the fusoritide, and uncontrolled narrow angle glaucoma. And undesirable effect of the tolterodine is xerostomia, weight gain, dysuria, headache, drowsiness. For solifenacin, it can be contraindicated in gastric retention, uncontrolled narrow angle glaucoma, and side effects are also the same like constipation, blurred vision, dry eye. And for propenthalin, it can cause the palpitation, tachycardia, bloating, constipation, vomiting, xerostomia. So anticholinergic side effects. Dosage for the 3 concurrent drugs for tolterodine, orally 1 to 2 milligram twice daily, or the 2 to 4 milligram once a day for sustained release tablet. For solifenacin, it can be initially started as 5 milligram once daily, and if tolerated, it may increase up to the 10 milligram once daily. And for propenthalin, oral dose is 10 to 30 milligram. Then other one is a phenazopyridine. It is an azodie which exerts the local anesthetic or the analgesic action on the urinary tract mucosa through an unknown mechanism. The pharmacokinetic of phenazopyridine is a metabolism in the liver and other tissue and excreted in the urine as a 66% unchanged drug. Indication for the phenazopyridine is a dysuria, symptomatic relief of the pain, burning, urgency and frequency. Contraindication is a known hypersensitivity to the phenazopyridine or any component of the formulation. Adverse reaction are headache, dizziness, stomach cramp, and GI upset is seen in the 10% patient and can be reduced by administering the drug with the food, and overdosage may result in the methemoglobinemia. Dosage for the phenazopyridine is 200 to 400 milligram TDS and available as a pyridium 200 milligram tablet. Baclofen, it is a skeletal muscle relaxant. Baclofen is a GABA B agonist and analog of the inhibitory neurotransmitter gamma aminobutyric acid GABA. So it is a GABA analog and has a presynaptic and postsynaptic action. At the presynaptic site, baclofen decreases the calcium conduction with resultant decreased excitatory amino acid release. And at the postsynaptic site, baclofen increases the potassium conductance, leading to the neuronal hyperpolarization. Additionally, baclofen may inhibit the release of the substance P. The figure showing the mechanism of the baclofen, it is a GABA analog, so act on the GABA B receptor and inhibit the voltage-gated calcium channel, inhibit the adenyl cyclase, and activate the inwardly rectifying potassium channel. Absorption is rapidly by oral, availability greater than 90% for oral, and onset of action is taken up 3 to 4 days, and peak plasma concentration is achieved within 0.5 to 3 hours. Duration of action 6 to 8 hours, and excreted unchanged in the urine. Indication of the baclofen are spasticity and spasm with concomitant pain related to the disorder, trigeminal neuralgia, migraine prophylaxis, neuropathic pain, hiccups, and the GERD. And contraindication is known hypersensitivity or the intrathecal baclofen contraindicated in the patient with active infection. Undesirable effect are the sedation, drowsiness, nausea, dizziness, fatigue, muscle hypotonia, dry mouth, vomiting, constipation, and diarrhea. And urinary frequency or the incontinence, dysuria, and hyperhidrosis. Cautions for baclofen are withdrawal. Abrupt withdrawal of the per-oral baclofen may precipitate the serious psychiatric reaction like agitation, confusion, hallucination, paranoia, delusion, or the psychosis. Thus, the discontinue by the gradual dose reduction over 1 to 2 weeks or the longer if withdrawal symptoms occur. And sudden withdrawal of the intrathecal baclofen or the failure of the intrathecal pump may lead to the potentially fatal withdrawal symptoms. Usual dose range of the baclofen are 40 to 80 milligram per day into divided dose. It can be start as a 15 milligram daily in the 3 divided dose. So we can start as a 5 milligram 3 times a day and increase by 15 milligram every 3 days as tolerated to the 60 milligram in divided dose. And maximum it can be used as a 80 milligram maximum dose. And for intrathecal also gradually we can increase and starting with 50 microgram, and if inadequate response we can repeat the dose with 75 microgram and increasing within 24 hours. Some research articles for the baclofen showing the benefits role of the intrathecal baclofen for the pain management and effectiveness of the oral baclofen in the management of the hiccups in the adult of the palliative care patient. Other skeletal muscle relaxant are the Clopertine. It is a aminopyridine. It acts indirectly on the NMDA receptor antagonist by activating the potassium channel. It binds to and activate the G protein coupled inwardly rectifying potassium channel and causes a dose dependent reduction of the NMDA receptor mediated rise in the intracellular calcium. So activation of this channel lead to the hyperpolarization of the neuronal membrane, and thus the neuron become the less excitable and stabilize the neuronal membrane. The drug activate the channel, so called the selective neuronal potassium channel opener, because it activate the inwardly rectifying potassium channel. The activated state of the cell membrane is brought into the resting state by the Clopertine via the activation of the inwardly rectifying potassium channel, which is shown in this figure, and activate the NMDA activation of the NMDA receptor, which is prevented by the Clopertine. Pharmacokinetic, it is by availability is 90% by oral route and 75% by the rectal route. Peak plasma concentration is within 1.6 hours, and half-life is for oral, IV, and rectal administration is 100 milligram. For 100 milligram, it is 6.5, 8.5, and 10.7 hours. Adverse effects are most common with dizziness, drowsiness, pruritus, dry mouth, and gastric fullness, nausea, and the muscle tremor, and other side effects including heartburn, vomiting, disturbed sleep, etc. Indication for the Clopertine is musculoskeletal pain, lumbar, cervical, spinal root pain, chronic tension headache, cancer pain, post-operative pain, and contraindicated for known hypersensitivity to Clopertine, and the hepatic encephalopathy, cholestasis, myasthenia gravis, alcoholism, biliary cirrhosis, and the liver disease. Drug interaction for Clopertine, it may increase the hepatotoxic potential of the paracetamol. Thus, the hepatic transaminase level should be monitored during the drug with paracetamol. Alcohol and other sedative, including the benzodiazepines, potentiate the tiredness and dizziness due to the fluppertine. Co-administration with carbamazepine is not advisable, and it may increase the warfarin toxicity. Dose for the fluppertine in adult, it use as a 300 to 400 milligram per day in divided dose, and in children it can be used as a in 150 to 200 milligram per day. And for rectal suppository, dose range are 450 to 600 milligram per day in adult and 150 to 250 milligram in children. This is an article showing the everything detailed about fluppertine. Then aperison and tolperisone, they are the centrally acting muscle relaxant. And antispasmodic aperison is an antispasmodic drug which relaxes both the skeletal muscle and vascular smooth muscle and demonstrate a variety of the effects such as reduction of the myotonia, improvement of the circulation, and suppression of the pain reflex. And tolperisone is a piperidine derivative and assigned to a group of centrally acting muscle relaxant and has been in clinical use for the decades. They are the centrally acting muscle relaxant which suppress the mono and polysynaptic reflex transmission by both the presynaptic and postsynaptic mechanism. They stabilize the neuronal membrane by reduce the sodium influx and reduce the amplitude and frequency of the action potential and inhibit the voltage dependent calcium channel. So thereby they reduce the transmitter release and reticulospinal facilitation in the brainstem. The adverse effects for the tolperisone and aperison are the drowsiness, dizziness, paresthesia, hypotension, abdominal pain. Less common are the emotional disturbances, scarring, skin lesion, erythema, and rare are the anaphylactic shock, angioedema, allergic reaction, and xerostomia. And for aperison, also the same as the tolperisone, like drowsiness, fatigue, headache, and very rare are the anaphylactic shock or the Stevens-Johnson syndrome. Drug interaction, tolperisone may be increase the level of the centrally acting other muscle relaxant, and the level or the effect of the tolperisone may be increased by NSAID. And for aperison, it may increase the effect of the ethanol, alcohol, CNS depression, opioid agonist, buprenorphine, ributylene, thalidomide, and zolpidem. And the effect of the aperison may be increased by the dronabinol, cannabis, tetrahydrocannabinol, doxylamine, and lisotide. Indication for the tolperisone are the myotonic symptom associated with neck, shoulder, arm syndrome, scapulohumeral arthritis, low back pain, hematopic lateral sclerosis, or the subacute myelooccipital neuropathy. And for aperison, also spondylolysis, spondyloarthrosis, cervical lumbar syndrome, arthrosis of the large joint, and rehabilitation after the orthopedic or the trauma surgery. It is contraindicated in the hypersensitivity to the tolperisone or the aperison and myasthenia gravis, and used with caution in patient with epilepsy, hepatic, or the renal impairment. Dosage for the tolperisone is tablet available is 50, 100, and 150 milligram, and in severe cases, dose may be increased to the 150 milligram 4 times a day. And for aperison, tablet as an immediate release 50 milligram, which can be used as a 3 times a day, and extended release tablet of 75 milligram, which can be used as a twice a day. Article showing the effect of the tolperisone as a central acting muscle relaxant with less sedative side effect. The other one muscle relaxant is a thiocolchicoside. Thiocolchicoside has a selective and potent affinity for a gamma aminobutyric acid receptor and act on the muscular contractures by activating the GABA inhibitory pathway, thereby behaving as a total muscle relaxant. GABA is a main inhibitory neurotransmitter in the human cortex. So GABAergic neurons are involved in the myorelaxation, anxiolytic treatment, sedation, anesthetics. So GABA can also modulate the heart rate and blood pressure. It has also the affinity for the inhibitory glycine receptor And the glycine is an inhibitory neurotransmitter and acts as an allosteric regulator of the NMDA receptor. So thiocolchicoside is a GABA analog and glycine receptor inhibitor. Rapidly absorbed after the oral administration and metabolized into the 3-dimethyl thiocolchicoside, and bioavailability is 25%. Time for plasma concentration 30 minutes. Half-life is 7.7 hours. And indication for the thiocolchicoside are painful spasm with degenerative vertebral disorder, vertebral static disorder, torticollis, dorsal spine, low back pain, traumatic or neurological disorder, and contraindicated for the hypersensitivity to the thiocolchicoside, pregnancy or breastfeeding woman, and woman of the childbearing potential. Adverse drug reaction for the thiocolchicoside are the nausea, gastralgia, diarrhea, skin rashes, hypotension, temporary loss of the consciousness, excitation, or the photosensitivity reaction. And cautions, the preparation should be taken after the food. In case of diarrhea, treatment should be stopped and alcohol intake is avoided during the thiocolchicoside. Dosage for the thiocolchicoside is 8 mg every 12 hourly, and for intramuscular it can be as a 4 mg every 12 hourly. Topically, it is used as a cream or ointment applied on the painful or contracted area. And hepatic impairment have no dose adjustment, and for renal impairment, in severe renal impairment, it is contraindicated. Some research articles showing the thiocolchicoside as a muscle relaxant in the topical preparation of the thiocolchicoside. The last one is dexamethasone. We have covered the more of the corticosteroid in the last lecture. So dexamethasone is a corticosteroid similar to the natural hormone which is produced by the adrenal gland, and it is a stereoisomer of the beta-methasone, the two compound differing only in the spatial configuration of the methyl group at the 16th position. The cellular effects of the dexamethasone in the inflammatory cells decrease the number of the eosinophils, decrease the cytokines, decrease macrophage, dendritic cells. In dendritic cells, it also decreases the cytokines and decrease the endothelial cell leaking. For airway smooth muscle, it increase the beta-2 receptors activity and decrease the cytokine. And in mucous gland, it decrease the mucus secretion. Glucocorticoid dexamethasone is an agonist of the glucocorticoid receptor and a minimal mineralocorticoid activity. And it is a long-acting corticosteroid with minimal sodium retaining potential, and decrease the inflammation by suppression of the neutrophil migration, decrease production of the inflammatory mediators, and reversal of the increased capillary permeability, suppress normal immune response, and induce the apoptosis in the multiple myeloma cell. Onset of the action for IV, it is rapidly, and in oral, initial response is 2 to 14 days, and peak response is within 4 to 28 days. Duration for IV, it is very short, and absorption for oral, it is 61 to 86%, and it is excreted mainly in the urine. Off-label indications for the dexamethasone, like for spinal cord compression, for nerve compression, breathlessness like pneumonitis, lymphangitic carcinomatosis, tracheal compression of the stridor, superior vena cava obstruction, obstruction of the hollow viscus like bronchus, ureter, gastrointestinal tract, paraneoplastic fever, nausea, vomiting in the cancer, hypercalcemia associated with cancer, and for the pain, it can be used in the tumor in a confined organ or the body cavity, like raise the intracranial pressure or the bone pain. Anti-cancer hormone therapy in breast cancer, prostate, hematological malignancy, and lymphoproliferative disorder. And in general use, it is used as a improve appetite and enhance the sense of the well-being. So it is a general tonic. Contraindication of the dexamethasone is a systemic infection unless considered to be a life-saving and specific anti-infective therapy is employed, and hypersensitivity to the dexamethasone. Prolonged course of the corticosteroid increase the susceptibility to the infection and their severity, and a small increased risk of the peptic ulceration with corticosteroid alone. But this risk is increased up to 15 times when it is used with NSAID, and the live vaccine should not be given with the dexamethasone. It antagonizes the oral hypoglycemic and insulin and antihypertensive and diuretic. Increased risk of the hypokalemia if high dose of the corticosteroid are prescribed within beta-2 agonist. Metabolism of the corticosteroid is accelerated by the anti-epileptic, and concurrent prescription of the corticosteroid increase the INR in the patient already taken the warfarin. Thus, the INR should be checked weekly for the 2 to 3 weeks when a corticosteroid is started or dose is altered. Side effects of the dexamethasone are the avascular necrosis of the bone or the cataract, diabetes mellitus, infection like candidiasis, septicemia, tuberculosis, mental disturbances, muscle wasting and weakness, osteoporosis, peptic ulceration, and suppression of the growth, and specific carcinoid features. If the long-term treatment of the dexamethasone greater than 8 weeks, carcinoid features include the moon face, buffalo hump, increased abdominal fat, reduced subcutaneous fat in the limb, acne, bruising, hirsutism, and striatum. These all are all about the adjuvant analgesics.
Thank you, Varun. So, Ravi, you want to summarize, and then we will take up the questions. There are, with the great difficulty, I can see two questions. I don't understand that why
Hello.
MDs are not having questions with these classes. Okay, go ahead, Ravi.
Yeah, good morning, everyone. Today we are cover adjuvant analgesic regarding first dose used in bone pain like dexamethasone, calcitonin, then other like used in GI tracts, buscopan. Hello. Hello.
Please go ahead.
Hello.
Yeah, go ahead.
Okay. Okay. We are using adjuvant analgesic in GI tract pain like buscopan, octaviotide, then other use in genitourinary tract like tamsilosin, sulfenadine, fluoxetine. Others we are using skeletal muscle pain like muscle relaxant, baclofen, thiacolchicoside, tolperisone. So we have used various type of adjuvant analgesic in pain management because pain is a multi-modality disciplinary. So we have not only pain only analgesic for pain source of pain. We have used according to the other effect or other mechanism of pain. So we have to try all analgesic according to the cause of the pain.
There are two questions. Would you like to take up this question? I will read the question for you.
Yeah.
The first question is, if you also see simultaneously that chronic, Dr. Sai is asking that chronic pelvic pain post-hysterectomy and intestinal cystitis, tried everything, gabapentinoid, TCA, Urispas, anything else she can do?
Yeah, if he tried every medicine, then we do intervention like superior or in superior hypogastric block or lumbar sympathetic block. If patient condition is good, you can tolerate intervention then.
Okay, so I think Dr. Sai, this is a very difficult task to manage chronic pelvic pain sometime. You have to try all these medication, but simultaneously we should definitely think for intervention and as well as non-pharmacological therapy, because Many a times non-pharmacological therapy will work, but definitely intervention can help in these patients. Next question, Dr. Ravi, is with the bioavailability of Buscopan, as Varun said, less than 1%. Can you please explain its effectiveness?
Is bioavailability is compared, oral bioavailability is less than 1% as compared to other routes, but it's work well while in case of irritable bowel syndrome or when there is a colicky type pain.
So basically, I think bioavailability 1%, but still it works for 4 to 6 hours. So
Yeah.
this is what Dr. Ravi wants to answer. Next question, Vishnu is asking, can you please explain how does calcitonin work in phantom limb pain?
That I don't know, madam. We are not much using it, but there is some literatures. They are saying they are using.
So there is for the calcitonin, use of calcitonin in phantom limb, well, it is not well established, because again phantom limb pain is a difficult entity and it is always, or we find it challenging to manage it completely or make it pain patients completely pain relieved. So there are short 10 or 15 case reports and trials as far as calcitonin for phantom limb pain is concerned. All of them have used it's like number of patients are very less. So it is not well established, but people have started trying calcitonin for phantom limb pain. So in case if you are finding it difficult and patient is not getting relief, again my recommendation will be try non-pharmacological therapy and intervention. But if you don't have all these facility or expertise, then you can try calcitonin and see whether it will work. So Neha answered about the instead of Buscopan orally, since it is a poor bioavailability, we can try cyclopam and dotaverine for spasmodic pain. So anyway, okay. So now we have 3 more minutes. So anyone wants to comments? I can see Nandani. Nandani, your comments for the class. Dr. Nandani.
Yeah, hi Sushma. I think these drugs which are very rarely discussed in detail, it's a wonderful thing that they are being picked out and being discussed with all the pharmacological details. So I just want to congratulate. Only thing, I think one thing we could add is each time they present, they should also talk about what is available in India, so that it just it becomes more practical then. And,
absolutely, very important, very important. So next time, say we should make an attempt what is available and what is the cost of everyday cost. If patient will take, what will be the cost for the patient, because there are many drugs which a common man cannot afford. So we should be having a balanced attitude of advising pain medication. So anyone wants to say anything? If you want to can raise your hands, and we have only 2 minutes. So if there are, okay, Dr. Preeti, yes, it is a very good suggestion, or tell whatever is okay, good suggestion that we should have what is available in India and at what cost. Good. So next time, please remember this we have to present. So thank you very much. And I think that in summary, we should learn everything, all the drugs, about all the drugs in details. And it is important that we should have a clear-cut idea about the drug interaction, its frequency, doses, and side effects, because our aim is not to make our patient life miserable by giving a lot of side effects and by not knowing drug interaction. So it is important to learn about all these medication in detail, so that we will have an idea, and probably in last we will have a lecture on drug interaction, common drug interaction of various medication, so that we will have clear-cut idea that when we are using this medication, we should be very cautious about using which medication. So thank you very much. Thank you, Ravi, and thank you, Varun. I know this is talking about these medication becomes sometimes monotonous, but you have attempted a lot to give details about the medication. And as Dr. Nandini has suggested, I think from the next time onwards, we should have an idea that will be the daily cost of the medication. Thank you very much. See you next Monday before 6:30. Thanks.